I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Friends. Welcome to another episode of Faisel Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is healthcare for all is justice for all. Robert, it is good to have you back.
Yeah, well, I'm glad to be back. I was very sad to miss last week, but we've been very busy with a number of pretty important staffing projects at our company. So I've been working quite a bit, but glad to be back this week and glad to be back for such an important topic in that healthcare is justice, and healthcare is something that we need to look at not as a commodity, not as like socialists benefit, as something that is an investment in society and one that needs to be done in an equitable fashion to promote justice. And I think it's a great topic. And I know we have a fantastic guest to join us today to talk about this exact topic. Yeah.
Yes, we do. I'm really thrilled to have Timshel Tarbet joining us tonight. Hi, Timshel.
Hi there. How are you?
I'm doing really well. You know, I must say, so Timshel and I spoke this past week, and I'm not kidding. It felt just like I was reconnecting with a distant cousin. I mean, just instant connection. It was just back. My wife was saying, "Are you sure that's the first time that you two spoke with each other?" I said, "Yes, this is the first time." And I tell you what, it's one of my favorite things. I just got active on social media last year. And one of my favorite things with COVID is just the way that we've been able to connect with people in this manner, how it's becomes acceptable. And really, it feels like a neighborhood. Like it's a wonderful community of there's such a huge community of like-minded people. And we're able to connect now in this manner.
Yeah, in ways that we haven't been able to in the past. The other thing I tell you is I'm adopted. So, hey, we could be related. You never know.
You never know. That's great. You know, when my background before joining ChenMed, I was the chief medical officer at Tampa Family Health Centers. It's a large FQHC in the state of Florida, one of the largest in the country. And while I was there, we had over 30,000 patients who didn't have insurance. Okay, and I remember, especially with conditions like hypertension, diabetes, with all the resources that we have available to us, especially in America. And you look across the country, it doesn't matter if you're talking Publix or ShopRite, Winn-Dixie, Food Lion, I don't know, what's a grocery chain store in Oregon that has the free antibiotics and the free blood pressure medicines. I don't know if you have them over there.
I'd say Walmart, probably. Yeah.
Walmart has over 80 medicines for $4 a month, cash price. Right.
Yeah.
$10 for a 3-month supply. And I remember I was with a nurse practitioner, and she was telling me about treatment-resistant hypertension. And she said that when I said, "Well, what is treatment-resistant hypertension?" And she said, "Well, that's when that happens in 10% of patients, and that means that they need 3 or more medications." So when she said, I said, "So you mean to tell me we can control 90% of hypertension with 3 meds?" And she said, "Yeah." And she did a little bit more digging in for me and found out that we can control 70% of hypertension with 2 medications. And 95% of hypertension has 0 symptoms.
Right.
So with people, now we have over 30 million Americans who don't have health insurance. We've got another, what's the number now of people who are functionally uninsured? They can't afford their copays or deductibles. It's 40 million, 60 million, something like that.
Yeah. Well, The typical number is like there's 10% ish of the population that just does not have insurance at the moment. And then the functionally uninsured is a pretty substantial number because of high deductible health plans and because of folks that are in sort of expansion populations or who end up just like not being able to actually afford healthcare. I don't know the exact statistic. I will have to check on that. I'll do that right now.
It's something like, it's like 40 to 60 million. It's a ridiculous number. And with hypertension, I pick on that because now half the country has cardiovascular disease, and it's led by hypertension. And when 95% of hypertension has zero symptoms, there are many people, if they don't see it and they don't feel it, they're just going to continue on with their lives. And if they don't realize it, that, hey, all they needed was one medicine, two medicines, maybe if they're in the extreme, 3 or more medications. Now with all the resources we have available, if they end up having a catastrophic event happen because of neglecting to have their blood pressure monitored or blood pressure put under control, that is completely unnecessary. The suffering that is caused from people not having access to medicines that are just widely available is complete injustice.
I can't agree more. I mean, one of the things that you said there, which really stands out to me, is copays could be as little as $4. But when you have individuals that might need 3 of those, and that's $12, and they don't have $12 extra a month, I mean, it's not even the high deductible plans. It's, some of those plans that are fairly rich, but people cannot afford. They do not have the income to afford their choosing. Do I eat or do I take my meds? And normally when they're in that kind of a spot and you start thinking about hypertension, you're also running into the fact that they don't have access to low-cost purchase foods that would also support it. So it's not just from a medication standpoint. I mean, it's just a whole person standpoint of not being able to access what they need to stay or get healthy. And then it becomes catastrophic where they end up with a large event and end up in the emergency room. And at that point, the costs are a lot more than $12.
Absolutely. I mean, that is what is bankrupting the country. The number one cause of bankruptcy in the country today is medical debt, medical billing. And it's not from the outpatient side. It's from the hospital side. America cannot afford this system where half of our medical care is delivered in the emergency room setting. I remember, I don't know, Robert, if I told you the story about my aunt a few months ago. It was the weekend after Thanksgiving. She has health insurance. She had Thanksgiving. After Thanksgiving dinner that evening, she woke up with headache and blurry vision and dizziness, and this continued on. She took a Tylenol the next morning. She kept on feeling lightheaded and dizzy. She had recently switched primary care doctors, and the first available new patient visit wasn't until January. And now she calls me on a Saturday, and at this point, she had a bloody nose. Is why she called me. She had a bloody nose, which is why she called me. And then I had her check her blood pressure. Her blood pressure was through the roof. I told her, I said, okay, she was only taking a low dose thiazide, 12.5 milligrams of hydrochlorothiazide. We had no other option. She had no other medication there. And I said, well, take an extra blood pressure pill and then check your blood pressure again over the next hour or 2 hours. She checked it. Her blood pressure came down. I told her to stop eating all the salt, be very tight with her with what she's putting in her mouth, and her blood pressure came down with 25 milligrams of hydrochlorothiazide. Thank God. That got rid of the headache, the blurry vision. She was having symptomatic hypertension. She was very, very close to having a stroke. And in fact, her mother died of a stroke, same age. And this is something that was that entire situation was completely preventable. And for most people, remember, when you have a headache or in hindsight, we'll say, well, of course, it's uncontrolled blood pressure, uncontrolled hypertension. But for the person who's in it in that moment, I'm going to take some Tylenol. She's like, if this was really a stroke, I wouldn't be feeling so terrible. There's no way that this could have been a stroke. Denial is probably I think it probably is the strongest human emotion. Dr. Dan, I am so sorry.
Yeah.
We've been talking and I didn't even introduce you.
Oh, no, that's great. That's great. It's great to be here with you all this evening. So we have Assad has made a comment. He was asking from Robert to elaborate what the most unjust segments he sees currently in healthcare And I would be interested to know what Timshel thinks about that as well. So
Absolutely.
I guess Robert and then Timshel, if that's okay.
Well, I would actually turn around and say, Timshel, please, why don't you go first? You're our guest, and then I'll jump in after that point.
Oh, come on, you're not going to let me ride on your coattails on that one?
Well, there's a lot of injustice and inequity that we see in healthcare, and there's a whole bunch of different ways to frame it. So, Timshel, I'll let you go first, and then I'll jump in. I have a couple that I'll throw in there, and then if we want to go in depth someplace, we can go in depth someplace. But I'll let you take this one.
I mean, I would say when I start thinking about injustices and health equity, I think there's, a lot of systemic problems that need to be taken care of. And, you can point to one or the other, and so many of them. If you are a woman, if you are a person of color, if you have lower economic means, those are all indicators that you're not going to get the same care as your counterparts. I mean, and so I think that it's hard for me to say, is there one that I would point out to and say this is more than or more important, because each of those affects an individual, and what might not seem as important to me is going to be way more important to the individual that it's affecting. And so I really, 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 when you think about healthcare for all as justice for all, I see it from that standpoint, which is I don't see it as one being more important. Each of it is incredibly important, and we have to figure out a way to fix this system so that there's zero injustice, and that no matter who you are, how much you make, or what your skin color is, you can walk in and get the same level of care and treatment for any situation, but especially those primary care ones that can really help, save your life long term. Robert, what would you add?
Yeah, and I'll go ahead and jump in too. I think at the very minimum, if we were thinking about sort of like big policy changes that can really help address inequity or these social determinants of health, I think that have come out in recent years that people like to talk about. And one of them is closing that gap of coverage in the United States. We're really the only developed nation in the world that has a portion of their population that does not have any form of healthcare coverage or health insurance. So that's at a very bare minimum going to solve a big problem. A lot of those folks are, they make too much money for Medicaid coverage, or they don't fit sort of a categorical example like pregnant women or parents of children, or they make just a little bit too much money to really be covered by Medicare or Medicaid, and then they're not old enough to be covered by Medicare. And so there's this group of people that they tried to address in the Affordable Care Act that would have been the expansion population. That could have gone into sort of this individual market, or that could have been able to gain access to Medicaid from states that actually expanded. And so like coverage is something that is just like a really low hanging fruit thing that we could do in the country to help address a lot of this. But the other things that we need to address are things like housing stability. We need to look at that with the lens of health, I think. So we know that patients that don't have stable housing end up having bad health outcomes and ends up costing a lot of money from emergency department visits, from hospitalization. And so being able to address housing across the country is something that would be a really tangible way to do so. And we know that low-income folks and people of color are disproportionately affected by homelessness, disproportionately affected by certain conditions because of societal inequity and because of poverty and a lot of systemic issues. And you see a lot of the effects of this come out from in healthcare costs. And that's why the healthcare system is particularly in interest in this particular space, because it's very, very expensive. And so not only is it the right thing to do, but it's also a good economic thing to do for the country and for our society.
I agree. I mean, it's like, otherwise it's like this circular thing, right? Because you don't have housing, you don't have education, you don't have access to healthcare, then you're going to potentially end up passing that on, and it just continues on and continues on and continues on. So they're all totally interrelated.
Yeah, it's a cycle. And so in the country, we've also like historically from a political perspective, like really segmented social supports and healthcare. So we've, for whatever reason, decided that they're not related. And I think the research world has really come up with the ideas that allow you to sort of connect them. And there's been a lot of research done in recent years that say, okay, a lot of these social factors and things that traditionally may have been handled like food insecurity or housing instability through completely other programs than health, we're obviously starting to be able to get into the common knowledge and into the political sphere, this idea that health and people's health is really affected by a whole bunch of different elements, whether it's individual lifestyle behaviors and diet, whether it's actual access to healthcare coverage and healthcare services, whether it's these social deterrents of health and environmental factors. Those things, besides like the actual access to healthcare, addressing a lot of those actually may have a whole lot more impact on providing better health in the country, or promoting health in the country. So I think getting people to think about health as something more than just like the physiology. And Faisel, we talk about this all the time. It's not just going to the doctor and figuring out what's wrong with the body system and solving that with a pill. There's a lot of things that go into affect how humans are able to relate to their medical care, how they're able to actually follow their doctor's orders, and how they get sick and how their health is actually impacted from their life outside of medicine or outside of the healthcare system. And getting that into the political sphere and having people pay close attention to that, because not only, like we've said, it's not only a good investment economically, it's also just the right thing to do for our society, hence the topic, justice for all.
Yeah, there's.
So,
no, sorry, Dr.
No, I was going to say, Elizabeth brought up a interesting question here, is how can we bring more attention to the inequities in this political climate? And I think just so everybody plays nice here, how do you find common ground about the inequities? What are the areas that the conservatives and liberals will both agree on that makes it important to address this? Because I think there are good arguments on both sides.
Yeah, and Faisel and I talk about this all the time, Dr. Dan, which is like, if you just go in there with the dollars and cents. We had an episode called the dollars and cents of like universal healthcare, right? And it was like, both sides can get on board with saving money and making investments that generate ROI for the taxpayers, if you're talking from that perspective. Now, if we're looking to be that, and we're just going to reduce things down to dollars and cents, investments in inequality and investments in healthcare access produce dividends for society in terms of productivity and in terms of reducing our healthcare spend for taxpayers and premiums for people paying into the commercial market. So that's one way everybody can get on board with it. Now, I don't think in the current political climate we can actually have those like in-depth conversations, because people are just like, have you ever seen the news in the past year? It's just insane. So trying to actually push through meaningful policy is becoming increasingly difficult. And my hope is that in the next several years, there's a lot more discussion and a lot more like focusing in on actual problems in the country rather than everything else that could go on politically. But I'll let somebody else jump in now. Faisel,
So you think that the way to find the common ground, like if you have the country, I think for like the last 10 or 11 elections, the popular vote has been 50-50, pretty close to 50-50. So if you have 20% of the people on the far left who have one strong opinion, 20% of the people on the far right who have another opposing strong opinion, I'm hoping that there are 30% to the left and 30% to the right who can find some common ground. And perhaps the way to move forward with the conversation is to establish that, hey, like we go at it from the dollars and cents, like really go at it and explain that, hey, you can't view it through the lens of the system that we have today. Today, we can't even call it a system. It's like some kind of feudal thing, like a fiefdom. If you I live in Tampa. If I go from Tampa to Miami and I seek medical care in Miami, they have no idea about anything about what my primary care doctor is doing with me, right? We don't have
put it.
Yeah, I know.
I was never thought about it like that before. I think that's pretty good.
Yeah, it's and so if we establish the fact with the people who have common ground that, hey, the drivers of the cost are hospital care. It's unnecessary hospital care, especially unnecessary emergency room care. We should just call it what it is. It's emergency room care. Most patients aren't direct admitted into the hospital. They're fed into the hospital system through the emergency rooms, all the emergency rooms, the ones that are attached to the hospitals and the standalone emergency rooms. So the number one driver of bankruptcy is medical billing from the hospitals. 1 in 5 Americans is in some stage of debt collection because of the hospital system. And we cannot afford the current system where so much of the population is getting their care in these settings. So we have to move the incentive from being rewarded with a bad flu season. A bad flu season equals huge profits for the hospital because we're only vaccinated. I think even now this year, we're only like 45% of American adults are vaccinated against the flu. So a bad flu season is great business for the hospital because there are complications from the flu, unnecessary complications from the flu, because we have low vaccination rates against the flu. So that then you move it towards a setting where the costs are significantly lower, and especially now with all the technology and all the resource and when I look at the medications and all the devices and just what we have available today, that I think the understanding needs to be that, hey, the driver of waste right now is hospital care. We can no longer afford this system that incentivizes hospital care. And I think that that's what would help move us from hospital care to outpatient care.
I mean, yeah, following the dollars and cents, right? From where are we going to incent and what are we going to try and drive to? But we have to make sure that we have enough of that other system to be able to take care of them, right? We don't want to just push people from the hospitals to primary care without having the right primary care people there who can address all of the different systemic issues when you start thinking, about the housing, the mental health. So I would almost take it a little bit deeper and think about, what are some of these root causes? Yes, the hospital system, we need to get people in primary care, but we also need to make sure that, we have all of those other things linked: mental health, housing, food insecurity. What are the desert areas where we don't have support right now? What do those look like? Rural areas where you can't drive, I live on a farm in Oregon. I'm sure people have seen the barn cats running around behind me. And, I'm not that far from the doctor, but if you go farther over in Oregon and you hurt yourself, you're either going to super glue it or, potentially, just wrap it up and keep going. So you have to make sure that we've got the right systems in place to support folks throughout our whole country. The other thing I think, one of the things, we are very politicized right now. There's very far sides, there's a lot of people that are easily swinging far one side or far the other side. But regardless, we all have stuff in common. And while instead of trying to point out how we're different, I really think that if we can all just take a step back and think about the fact that nobody really is trying to hurt someone else or wish ill on someone else, and start from the fact that we're wanting to do the right thing and help and come from that common ground, maybe we could get to a point where we could start to solve the problems.
Mm-hmm. Yeah. And Timshel, could you tell us a little bit more about, where you work now and how you at SCAN think about, tell us about your patient population, tell us about your philosophy on care, and tell us how you think about this sort of justice idea and how you think about addressing social determinants.
Absolutely. So I am at SCAN Health, which is, we are a Medicare company down in Southern California. I say down, I just started in December and I'm still in Oregon. So I will be down there at some point. I'll leave the cats here. But it's an organization that is so amazing, because when I look at it, established by 12 seniors, over 40 years ago, that were like, hey, there's a problem with the system, and we want to come in and we want to fix it, and we want to, figure out a way to, really do amazing things within the communities that we're in. And so, when I got approached about coming into SCAN and, working with across the organization, really focusing on, diversity, equity, and inclusion, not just from an HR standpoint, but from, I report to the CEO, and I am doing work with our sales, with our marketing, with our network. really trying to meet each individual where they're at as they're getting healthcare. The majority of our population are seniors, but we do have folks that are, on Medicaid, and so under that 65. And, we're really looking to change the way that we're doing it in some ways, meeting the members where they need to be met, thinking creatively about what that means, whether it's, from a cultural standpoint, from, a historical standpoint. How can we make sure that, we are meeting each individual where they need to be met to get their care? And how can we best help them in doing that?
Excellent. And it sounds to me like SCAN, actually, you should meet ChenMed if you haven't already, because if you want to provide a very high level of care for your patients and your members, that's the population that ChenMed cares for under full risk. So
Yeah.
I don't know if I know ChenMed's not in Southern California yet, but this might be the great opportunity for both organizations to start working together.
Now I know why I'm here. Sales call, huh?
I think we're gonna see more of this movement. There's going to be more of a movement away from fee for service, away from the transactional, reactive nature of care, and this care that you and I, the world that you and I both live in, where we go to where the need is, where we both see that the areas of most need is where we find the greatest opportunity.
So Faisel, Rosanna Lee, I hope I'm pronouncing her name correctly, that looks like she's also at SCAN Health as a social worker. And she's talking about many organizations don't have the resources to handhold individuals who have needs for a higher level of assistance. And I mean, I know it's often difficult to even get people to provide the paperwork. So at least in some of our markets in ChenMed, we have 25% of the patients are dual eligible, but probably half again as many are, they actually are on Medicaid and Medicare, but half again as many more would qualify if we could ever get the work done, but there's nobody to help them do that. So it's not simple. How do we help people do that?
So I have to jump in here, and I'll be brief, but when I was at the Institute for Medicaid Innovation, we did a whole project on the Medicaid enrollment process and the Medicaid enrollment form, and published a paper. And we looked, I might be the only person in the country that's read every single state's Medicaid enrollment form and gone through question by question. And we did a full analysis of what kind of content was asked, how difficult it was, all that fun stuff. And it's so hard to fill out. I was sitting there, and I have, I've gone through college, and, I've studied healthcare and studied Medicaid, and, I can sit there and go through it, but I don't know if I could answer the questions myself. So we have a population that may have limited education attainment, that may have limited reading levels, and we're asking some tough questions. I don't even know where to find some of the information. So
they might also have
the process.
They might also have limited time, right?
Yeah.
So it's not even about, health literacy, but it's about, do I have time to sit down and to actually fill this out, or do I have to keep going and doing these other things? So
I work several jobs, and I can't necessarily get to fill out the benefits stuff, or I have to go fill it out in person at a location, or I have to do it over the phone. And many states started rolling out online enrollment processes that were more efficient to walk patients, or I should say members or patients, individuals through the process. But many more still haven't modernized that enrollment system. And often intentionally, because if you have more people who are eligible for Medicaid and benefits enrolling in Medicaid and benefits, you have to spend more money as a state. So there isn't much incentive there for them to actually improve the process if they want to save money. Some states actually see this as an investment. They do a good job. Others, not so much.
Gosh, and that's a problem that we see over and over again. The short-sightedness. There's definitely some short plays that you can help improve, by reducing unnecessary hospitalizations, reducing the ER visits. But then there's the longer plays too, like with pregnancy Medicaid. All the controversy around pregnancy Medicaid. Well, now you look, 30 years later, 30 plus years later, the children of mothers who had pregnancy Medicaid had higher levels of education, they get better paying jobs, and they've paid more into the system than it cost to begin with. It makes good sense, but it wasn't something that you could see in 1 year to the next. So there are definitely some plays that are longer plays, but I feel that in just the short term, if we just viewed increasing access with Medicaid as increasing access to primary care, because right now the other thing is that the current system, there's an incentive where you have 80% of the doctors are specialists and 20% of the doctors are primary care doctors. We have an entire system that is lopsided. And for the states that are viewing increasing access or making it easier for patients to access Medicaid, I mean, my goodness, I don't think it's ever been easier to just. I've been doing Valentine's Day shopping for my wife. Went to a website, just looked up my phone, and it picked up all my information. It was a random website, had my address, everything. I didn't have to do any work. And I was done. And I moved on with my life in less than a few minutes. For something as vital and as important as the health of the country, we cannot afford to not insure them because they're getting their care and they're continuing this culture of care in the hospital rather than in the primary care outpatient setting.
Well, just providing coverage and giving somebody access to a PCP is extremely good investment because it routes somebody from the emergency department to get into telecare. So, if you don't have health insurance and you know that they're going to have to treat you or stabilize you at an emergency department, then as an individual who might be uninsured, that's where you go when you need health care. And so just giving people access or providing access to Medicaid and then a PCP is just a much, much cheaper intervention to actually save money and provide better long-term outcomes, like we're saying. And Faisel, we always talk about how, like, okay, it's really hard to convince people that you can make an investment in health. People don't actually have a good sense, like non-healthcare people, I should say, don't have a good sense of actually doing really effective interventions, having really effective care, and then actually seeing clinical benefit. Most people think health is just oh, you get sick or you get a chronic condition and you're stuck with that forever, because our healthcare system sort of reinforces the idea that you can't really do very much with that in the general public's eyes. So when you try and make an argument politically to actually improve some of this or provide, universal care, you have to go about it in such a way that you can actually educate politicians and the general public that good primary care that's not in a fee-for-service volume-based system can produce better health outcomes in a year, in 2 years. And that is a good intervention.
You think it's just a generational thing? Sorry, Timshel.
No, I was going to say, one of the things that you said was better health outcomes, and I would almost change the wording a little bit to say better outcomes, right? So if you're not just focused on healthcare and you're looking at the whole person, if you start having better outcomes, then maybe it changes the conversation a little bit, because if we're having healthcare conversations, that's one thing. If we're having person care conversations, that's something different, right? And I think what we're really talking about is we think about primary care, making sure that you have housing security, making sure that you have that basic level of security is person care and not just healthcare.
Absolutely.
I agree. Timshel, when COVID hit, we actually had a meeting with our CEO. And he gave an order basically across the entire organization: do whatever you need to do to keep our patients safe. This virus is killing seniors 10 times more than it is a younger population. So our patients are at the most at-risk population. And he said, you know what I mean by that? If they need groceries, you go buy groceries for them. If they need toilet paper, you go buy toilet paper for them, you deliver it over to their homes. You do whatever you need to do to keep the patient safe. And from that, we have actually grown exponentially from those, because like you said, it's looking at the entire patient. When patients have little small concerns, we need to address those concerns before they become bigger ones. In fact, we even developed an entire program called Love Calls, where every patient gets a weekly phone call at least once from their care team delivery team. Every patient gets a daily text message, staying so tightly connected with the patients so that they automatically come to us with the big stuff because they know they can trust us with the little ones.
Well, and that's just building trust in the system, right? And building trust within those. I mean, this is a relationship. If you're expected to go into your doctor and share all of these personal things about you, and you're just a check the box activity so your doctor can move to the next room and get another billing code, as opposed to knowing that, you know, who you are as a human being matters to those that you're then going to be sharing some of your most personal information from. I mean, you're building a relationship.
You know, I was on a call earlier today, and the system of patient-centered medical home, like the patient-centered care delivery system, that we should modify that to the doctor-patient relationship-centered delivery of care, where the doctor and the patient, because now we have physician burnout at record levels. America's doctors have now become the patients. So we need a system that takes care of both doctors and patients. And at the end of the day, what good are we to the patients if we don't take care of our doctors first? Just saying.
Mm-hmm.
Agreed.
And the evils of fee-for-service will continue to plague us until we move towards a more value-based payment system.
Yeah. I mean, and you know, the interesting thing is that now, like, almost half of the reimbursements are value-based. But the issues is that they're still rooted in fee-for-service. 95% of the system is still fee-for-service. So when you have these hybrid plans that are rooted still in fee-for-service, you still have the RVUs, you still have all the CPT codes, you still have all the documentation that is to justify the billing rather than explain the situation that you're dealing with the patient right in front of you.
Yeah, or, you know, justify what you need to do with the patient rather than, you know, actually like what you need to do with the billing people.
Yeah,
which is never a good thing. I really like that both of you are on here. I think we're probably going to wrap up after we kind of say some final points here. But I like how, Timshel, you're at a health plan, and Faisel, you are a provider organization, full risk practice, right? Multi-state, full risk practice. It's so nice from my perspective to see that there are organizations on both sides of that equation, which is often contentious in traditional healthcare arrangements, where we can come together and work with providers or with payers to be able to build a system that works better for physicians and produces better patient relationships, and therefore often better patient outcomes. And I think that that's something that is becoming more common as everybody starts to get on the value-based payment train, on the whole person care train. And I've seen a tremendous amount of transition to this in the past 2 or 3 years, which has been really nice to watch. For our last points, I'd like everybody to share sort of, you know, one hopeful thing about related to the topic, healthcare justice, that you can see and then happening in the next 2 years that might be really beneficial. And I know I'm putting everybody on the spot. As I sometimes do.
Well, what you were describing earlier, it does feel like a little bit of a utopia, right? Because in healthcare, typically, like you said, you don't have people from different organizations working together towards the common good, because the incentive in fee-for-service is to generate revenue by billing, whereas the incentive in the full risk value-based care system is to generate revenue by making people healthier. And when the incentive is to improve the patient's health, basically healthcare systems and healthcare delivery systems that do well, they do well because their patients are doing better. Their patients aren't going to the emergency room. Their patients, if they need specialty care, are getting appropriate specialty care to avoid going to the emergency room for hospitalization. I mean, going to emergency room is because of medical complexity, of course, is a big driver. But of course, there's a lot of social issues because of not having the proper social support systems. They end up going out of desperation. So I feel like we're in a really good place here where we can show that actually you can have a healthcare delivery system where companies do really, really well when their patients, when the focus is on prevention and early, efficient, effective intervention.
Excellent. Timshel.
I mean, I definitely agree with that. I think one of the things that I am hopeful for right now, with what I'm seeing around the COVID vaccine rollout and what's going on, is we're seeing that some of the institutional challenges and racism issues that have happened are being addressed. And so my hope is, as they continue to be addressed, we can start to rebuild some trust with some groups that really need that. And I think once that happens, we can, talk about what's been done, but then lean in and rebuild some of that trust so that long term, hopefully people will engage with the system more than they have in the past, and that trust will be rebuilt, and we'll have better outcomes from that.
Mm-hmm. And I'm certainly echoing that. I was gonna say, echoing that, I'm excited to see like a rethinking. I don't know how to put this, like a new frame of mind amongst healthcare leaders. And that it's not that you're providing just like a place for patients to come and get a service. It's that health is more holistic, and it's not just, on the patient to come to the clinic and be responsible. It's that the system needs to really reflect what that patient needs and make it a welcoming place, as well as a place that promotes good, positive patient engagement. And I think we're starting to see those mindset shifts to say, okay, look, we have to address more factors than just physiology. And we also need to make ourselves more accessible and reduce barriers to actually accessing our healthcare services. And I think that mindset's starting to become clearer amongst healthcare leaders. And I know both of you clearly understand that. And I'm always hopeful talking to our guests because of that reason.
Yeah, health is a lot more. It's a lot more than just medications and seeing different doctors. Health is coming to the centers for bingo. Health is coming to the healthcare center for karaoke. Health is coming to the healthcare center for exercise classes and Tai Chi. Health is a lot more than just doctors and pills. Well, Timshel, thank you so much for joining us tonight. The time flew by.
I know. Thank you for having me, I guess, cousin.
Yes, you are. We are definitely distant cousins. I feel it.
There we go. I'll take it.
Be careful. Faisel's going to invite you to his house at some point soon, too. So that's how it works. Everybody becomes best friends with Faisel after you come on the show.
That's what happens.
Tampa.
Perfect.
At the bare minimum, we are kindred spirits. And yes, I live 20 minutes north of the airport in Tampa. So when you come to Tampa, I better not find out that any of you go stay at a hotel. I have a home, and my home is your home. To Dr. Dan. Dr. Dan, I apologize for not bringing you on right away in the beginning. We just got right into it. We were so...
No, this is great. I love this conversation. I mean, this truly, it's time. I heard Don Berwick talking about the moral determinants of health. And the point being is you've got to do what's right. And at some point, we all have to decide we're going to do what's right to take care of everybody else. And if COVID has not shown us one thing, it's that we're all in this together. I mean, we all are in this together, and everybody's health depends on everyone else's health. So I think you all did a great job this evening, and it was a lot of fun. So it was great.
It definitely was. I think, Dr. Dan, we'll get there. We'll get there. People understand that freedom isn't free, and one day people will understand that justice isn't free either. So to anyone joining us, the comments, we love the comments. We love the interaction. Thank you so much for joining us tonight. For more information about today's topic and to explore career opportunities with ChenMed, please visit chenmed.com. We're on track to open another 400 to 500 centers over the next 4 to 5 years across the country. That means that we're going to need doctors, nurses, a whole bunch of healthcare people. We believe access to primary care is a right, not a privilege. Have a good night.